Today we will discuss how to read a CT PNS and the stress will be more on the surgical aspects. So CT PNS is very important for surgical planning. For diagnosing a case, MRI is important, but for planning a endoscopic endonasal approach, a CT PNS gives a very valuable information. It has to be done in very thin slices, preferably 1 mm or less, because thick slices will cause missing of information. So it's better to have thin slices as thin as possible. To start with, we have to see from anterior to posterior, and the coronal cuts gives the best information when we are planning for a endonasal endoscopic approach. So here we are having a thin CT of a patient who was a patient of pituitary mass. The scan was done pre-operatively, but for knowledge, we will discuss this scan as as any other scan. So we have to come from anterior to posterior. The as we go posteriorly, the first thing is to have is the this white thing, that is the nasal bone. And as we go posteriorly, there will be two nasal processes. These are two nasal cartilages. Anteriorly is the mucosal cartilage of the septum, and laterally is the ala. And here is the skin or soft tissue of the frontal bone. As we go posteriorly, we are starting to see the frontal bone. As we go posteriorly, we are starting to see the frontal sinuses. Now, as we go posteriorly, we are starting to see the frontal sinus septum, intersinus septum. Then there can be many frontal sinus septas, and the main septum will be the one which is dividing the two frontal sinuses. Here we are seeing the broadening of the nasal bone, and as we go posteriorly, the floor of the frontal sinus is formed by the frontal beak. Beak is the posterior part of nasal bone, which forms the floor of the frontal sinus. Now, as we go posteriorly, you see multiple interfrontal sinus septas. Now, as we go posteriorly, the nasal processes are becoming long. And now we are seeing the first cell in the anti-ethmoidal air groups. This is the agar nasal cell, and it is very well seen in the sagittal section, which I'll be showing. Here you are seeing the agar nasal cell, and the agar nasal cell is bounded anteriorly by the frontal beak. It is bounded posteriorly with the frontal recess. So this pathway, which is the drainage pathway of the frontal sinus, is known as frontal recess, and it is in the posterior boundary of the agar nasal cell. So when there is inflammation, or whenever we are working in this area and cause accidental damage to these cells and cause blockage of frontal recess, that can cause the mucocele of frontal sinuses. There can be a cell superior to the agar nasal cell, which is the frontal cell. And Kuhn has divided these cells into four types. Type 1 is a single cell. Type 2 is presence of two cells. Type 3 is whenever the cell is bulging into the frontal sinus. And type 4 when there is single large frontal cell, independent and only present in the frontal sinus. So this is important surgically because we can damage and can block the frontal recess and can cause resulting into the frontal mucocele. So how to work in this area? If we want to reach to the frontal sinus, like in a case of CSF rhinorrhea, we have to take a 70-degree scope, and we have to take a J-shaped curate and break the agar nasal and the frontal cell, and then we can reach and see the frontal sinus and see where is the leak site. So this is important. Another important thing is presence of supraethmoidal air cells. These are the cells of supraethmoidal air cells. These are also important because the skull base is very thin here, And without knowledge, we can damage the skull base and can cause iatrogenic CSF leaks. So coming back to the coronal sections, agar nasal cell. Now, as we go posteriorly, so now we are starting to see the maxillary sinuses. And when the maxillary sinus has started, that means the frontal sinus has been finished. Also, the crista galli, which is starting, this is also when the frontal sinus has finished. So, crista galli is the superior projection of the nasal septum. This is the crista galli. One important thing when we are working in the anterior ethmoidal air cell group is to work laterally. Because medially the cribriform plate is very thin and can cause iatrogenic CSF leaks. And the ethmoid air cell groups, they go laterally. Here you have a certain degree of advantage of safety. Also, you can see a lot of fat in the anterior part of orbit, which goes absent as we go posteriorly. You see the fat is decreasing, decreasing, decreasing more. So whenever we are working in the anti-ethmoidal air cell group, our working should be directed more towards laterally. And as we go posteriorly, the working should be more towards the medially. Here the fat is less and the bone in the posterior aspect is quite rigid. Another important thing is to look for turbinates. The first turbinate in the inferior part is the inferior turbinate, which can be bulging, can be large because of allergic phenomenon. Behind the inferior turbinate is the valve of Hassner, into which the nasolacrimal duct drains. Here you can see the nasolacrimal duct is coming from this part. Here coming, and this is draining into the inferior turbinate, behind the inferior turbinate into the wall of Hassner. Then this is the middle turbinate. So the middle turbinate has three attachments. First attachment is in the sagittal plane to the junction of the medial and lateral lamella of the cribriform plate. So this is important because when we are lateralizing the middle turbinate or when we are resecting the middle turbinate, we should not pull the middle turbinate because that can cause iatrogenic CSF leaks. So it is safer if we want to take out the middle turbinate, first to coagulate this attachment and then cut it sharply. As we go posteriorly, the middle turbinate turns laterally to attach to the lamina papyracea. And this marks the junction where the anti-ethmoidal air cell group finishes and the posterior ethmoidal air cell group starts. And as we go posteriorly, the middle turbinate turns and attaches to the posterior medial wall of maxillary sinus, that is the palatine bone. So this is important. These three attachments has to be remembered whenever we are resecting the middle turbinate. We have to coagulate and cut. We should not pull them. So as I said, the ground lamella is this, and before that there were anti-ethmoidal ASL groups, multiple small anti-ethmoidal ASL groups. The orbit was large. The maxillary sinus were flattened. The floor of the skull base is sloping, and as we go posteriorly behind the ground lamella, the posterior ethmoidal ASL groups are cells are larger compared to the anterior one. The maxillary sinus has become oval, the orbit size has become small, the fat is lost, and the floor of the skull base is flattened now compared to the shallow skull base present anteriorly. So that's why it's recommended that whenever we are working in the anterior ethmoid air group, we have to work more laterally. Okay, laterally. The medial part of bone is thin, can cause CSF leak. There is advantage of fat laterally in the orbit. And as so we should work more in the lateral aspect. And as we go posteriorly, the orbit is small and the floor of the skull base is thick. So therefore, we have to work more in the medially. This is the attachment of superior turbinate to the skull base, and from here, as we go posteriorly, we will reach to the sphenoid sinus. So the sphenoid sinus opening will be between the superior turbinate and septum. So we have to work medial to the superior turbinate to reach the sphenoid sinus. Another important thing is to look for the anti-ethmoidal artery. So anti-ethmoidal artery comes out from the orbit, and where the orbit forms a beak-shaped structure, and this is where it comes out from the between the medial rectus and superior oblique, and it comes out from the as a branch from the ophthalmic artery, goes to the skull base, then comes back, uh, returns to the nasal cavity to supply the septum. So here we have to be careful, and if we damage this artery, the artery can retract into the orbit and can cause the orbital hematoma. So this is one clinical aspect. Now, how to see when the ethmoids are finished and the sphenoid sinus is starting. So this is important. Uh, as we go posteriorly, the ethmoid air cell, as I said, the skull base is shallow. This will become flattened, and the superior turbinate. This is the septum, and behind that you see the now here is the sphenoid bone, lesser wing of sphenoid bone. So before that it was the frontal bone, and behind we are seeing the lesser wing of sphenoid bone. So here will be the sphenoid sinus. This is the area for the superior orbital fissure, which is between the lesser wing and greater wing of sphenoid bone. As we go posteriorly, we are seeing the optic canals. This is the inferior orbital fissure. As we go posteriorly, here will be the area for the optic chiasm. Now this is the with the median lateral pterygoid process and harnessing the pterygoplatean ganglia. So in the floor of the sphenoid sinus, yes. So in the floor of the sphenoid sinus, there will be the area for the Vidian canal. So Vidian canal comes anteriorly from the pterygoplatean ganglia. So this is Vidian canal, and this is actually having clinical importance because this marks the level for the internal carotid artery. So whenever we are not having the navigation, we can just make a guess based on the Vidian canal. This is the area for the maxillary nerve. Medial and lateral pterygoid plates. And this is the area for foramen ovale. So you should look all these things. Another important thing is this anticlinoid process, and this is optic strut, which differentiates, which makes the boundary between the optic canal and superior orbital fissure. In the sphenoid sinus, in the upper and lateral boundaries, you should see whether there is any bony deficiency to the optic canal. Here, the bony walls are normally and intact. If this air cells would have extended to the optic canal, that is known as an Onodi cell. The surgical importance of that is when we are going and drilling the anterior wall of sphenoid sinus, if we keep on drilling and there is presence of Onodi cells, we can directly land up into the optic nerve and may cause damage to it. So one should be well aware of the Onodi cell before embarking on this surgery. The nasal septum, if we trace it posteriorly, there is deficiency in the posterior part, and the nasal septum that continues to form the floor of the sphenoid sinus, which is known as rostrum. And this is a very good landmark to define the midline of the sphenoid sinus. There can be the sphenoid sinus septas, which are to one side, but the sphenoid rostrum is always in the midline, and this guides us and acts as a navigation. Axial plane gives a lot of information. Firstly, you can see the deviation of nasal septum. Then you can see the orbit, which is having more fat anteriorly compared to posteriorly. At the level of the cavernous sinus, Here is the area for the superior orbital fissure. This will be the optic strut, and here will be the area for the optic nerve, which you can see in thinly in this CT scan also. So here the optic nerve is coming and coming to the area of the chiasma. So a lot of information is seen in the CT scans. In the sagittal scan, as I said, it is very useful for seeing the agar nasi, frontal cells, frontal recess, superior ethmoidal air cells. And it's also very useful to see the type of the sphenoid sinus. We all know that the sphenoid sinus is, if it is well pneumatized, it's a cellular type, partially pre-cellular type, and it can be fully obliterated, known as conical type. So it helps in deciding the surgery. One should look for the osteomeatal complex. So in the lateral part of the middle turbinate, the free structure in the lateral wall of nose is the uncinate process. So there can be pneumatization of the uncinate process. The uncinate process, as we trace from posterior to anterior side, it goes up, and this guards the drainage of the maxillary sinus. So the semilunar channel between the uncinate process and the bulla ethmoidalis is known as hiatus semilinaris. And if we are going to operate in the for the medial orbital lesions, we have to take this pathway lateral to the middle turbinate, and then we have to resect the uncinate process, bulla ethmoidalis, and then we can reach up to the lamina papyracea. For approaching to the lateral sphenoid sinus leaks, one also has to take the approach lateral to the middle turbinate, take out the uncinate bulla ethmoidalis, and then go and drill out the pterygoid bone here, and can then approach to the lateral sphenoid sinus leaks. Also very important is when we are going to operate the pituitary tumors and we lateralize the middle turbinate, at the end of the surgery we have to again medialize it to let the opening of the maxillary sinus patent. Otherwise, that can lead to blockage of maxillary sinus and mucosal and other complications. So to summarize, one should have thin section CT scans. One should see all the sections slice by slice. One should not jump to the pathology. CT scan is for planning the surgery. The MRI is for diagnosing the pathology. One should go slice by slice from anterior to posterior. He should see in all scans, particularly in the coronal sections, because when we is operating endonasally, and you should see how are the turbinates, inferior, middle, and superior. Are there any extra cells, any abnormalities, and any deviated nasal septum? One should see the sphenoid sinus septas. There can be sphenoid sinus septa which can go and directly attach to the carotids, and sometimes the carotid wall may be deficient. The other deficiency like onody cells, and then we should plan the surgery accordingly. Hope you have found this lecture useful. Thank you.